Good afternoon. Welcome to our webinar. Hello, I'm Dr. Michael Kropp, President and CEO of Independent Health. I also serve on the board of the National Forum and chair the Value and Access Collaborative. I welcome you all to this roundtable on community pharmacists' impact on cardiometabolic health. We'll have a great and informative discussion of the role and the significance that community pharmacists can play in team-based care, particularly in assuring that there's access to quality health care for all people. Many of you participated in the development and issuance of the Value and Access Collaborative's joint policy statement on expanding access to care. So you already know that pharmacists and pharmacies play vital roles in healthcare. Today, we'll learn more about the evidence showing how pharmacist services and team-based care can improve cardiometabolic health. So it's my pleasure to introduce our panel of speakers for today's discussion. Ben Blumel is the Executive Director and Senior Vice President for Research and Innovation at the American Pharmacists Association Foundation. Along with his 27 plus years as the principal architect for the clinical and technology models in the Foundation's patient care programs and 12 years of pharmacy practice experience, Ben is the author of numerous innovative healthcare software applications and professional journal publications related to his work on collaborative practice, health information technology, interdisciplinary patient care, and quality improvement. He works with pharmacists, physicians, payers, technology companies, research, and public health organizations across the country to design and implement innovative, patient-centered, team-based care programs and healthcare service delivery systems. Elisa Bernstein, PharmD, JD, and FA, PHA, is Senior Vice President for Pharmacy Practice and Government Affairs at the American Pharmacists Association. She's responsible for leading the development and implementation of the association's strategies, policies, and programs related to pharmacy practice, advocacy, and government affairs, while guiding the organization as the voice of pharmacists in all practice settings. She joined the organization in 2019. From June of 2022 to July 2023, Dr. Bernstein was the interim CEO and Executive Vice President at APHA, the first female to lead as CEO in the 170-year history of the organization. She has also over 30 years of experience advocating for pharmacy and patients at the U.S. Food and Drug Administration, where she held several senior leadership positions. Last and not least, certainly, is Dr. Warren Jones, the Chair Emeritus of Family Medicine at the University of Mississippi Medical Center. Dr. Jones has over 40 years of experience in healthcare. Notably, he founded and established the Mississippi Institute for Improvement of Geographic Minority Health and Health Disparities at the University of Mississippi Medical Center. His other professional experience also includes directing the state of Mississippi's Medicaid program. Additionally, he was elected the first African-American president of the American Academy of Family Physicians. We are set to have a great and informative conversation. During today's event, you can utilize the Q&A feature on Zoom to pose questions while the panelists speak, and we will address them in the Q&A portion later in the discussion. But if you have comments, you can always put them in on the chat function while the panelists are speaking as well. Audience members can upvote questions that seem particularly interesting, and those questions will rise to the top to help assure that they are noticed and addressed. So now let's first hear from Ben Blumel. Ben?
Good afternoon, everyone. Really excited to be here today to share with you some background on the role of the pharmacist in interprofessional care. For those of you on our Value and Access Steering Committee, As Dr. Kropp mentioned, you're familiar with some of this, but we're going to give you a little bit of a look into the way back with some context about a practice model in the lipid management space. And then we'll fast forward into some of the other work that we've done over the years and the current projects that we have going on to hopefully give you some good context in terms of how the pharmacist can be actively engaged as a productive member of the healthcare delivery team. One quote that I really like is here on the opening slide that is from Alan Kay: "The best way to predict the future is to invent it." And that's what we're trying to do in a lot of these initiatives. So on the next slide, we'll take a look at some of the major risk factors when I started at Team APHA for coronary artery disease. And in particular, the challenge that existed then is that we didn't have good team-based care in place that helped patients to actually leverage the medications that have been prescribed to them to achieve their therapeutic goals. And there were a lot of really difficult things going on throughout our society. So on the next slide, we come a couple of years forward from that one. And you can see that even detection and treatment was pretty challenging at that point in time. But particularly for those with existing disease, the number of people who were prescribed a medication for which they were indicated was abysmally low. So if we look at the next slide, a challenge that existed both then and now, I'm sad to say, is that a vast majority of patients who are on medications for chronic silent conditions simply don't continue with them. And this declining curve for a 12-month cycle for lipids at that point in time showed that only about 40% of patients remained on their meds at the 12-month mark. And so even for that small number of people who we identified and prescribed a therapy for, we were having serious challenges. So on the next slide, you'll see what we tried to do with Project Impact Hyperlipidemia. And that's basically to get patients and pharmacists and physicians and other members of the healthcare team all working together to actually see if we could bend that adherence curve and actually get more people treated to goal. So on the next slide, you'll see that essentially we had a total of 397 patients throughout all of these sites across the country. And over a 24.6-month period, we saw a persistence rate of over 93.6%. Compliance was also high, above 90%. But strikingly, we had 63% of patients who were treated to their NCEP goal. And if you go to the next slide, you'll see the data and the movement that actually occurred in their LDL levels to make these changes, all of which are significant, and we'll summarize them in just a couple more slides with information. But on the next slide, you can also see that we have some relevant historical norms here. And so the LTAP study, the one in the pink bars on the chart, essentially was a study that didn't include pharmacists. And it didn't have a team-based care approach, but it did have a very aggressive approach to treatment nonetheless. And you can see that the achievement benchmarks in the populations were very significantly improved when you had the team working together in the impact initiative. So the next slide gives us a summary of what we saw. And so certainly these persistence and compliance numbers, exceeded anything that we had seen from this type of care delivery from a historical norm perspective. The improved persistence and compliance contributed to that achievement of their lipid lowering goals. And most importantly, the 22.1% LDL-C reduction and the 14% HDL-C increase really translated to a potential 34 to 40% reduction in cardiovascular events in this population based on the randomized controlled trial data. And so essentially, this was one of the early efforts from our organization that really got us excited about the potential for patient-centered team-based care. So on the next slide, you have an overview of these goals, and obviously increasing, the seamless flow of information between and among the members of the team, increasing the availability within these practice settings with point of care testing in these community pharmacies to provide surrogate markers and information upon which both pharmacists and physicians could base their clinical decision making was super important. And at the end of the day, in addition to really being focused on improving patient care, the goals are really to reduce the total costs for care to the system over time. So if we go to the next slide, you'll see a variety of different logos on the screen, and I'll point out some of these along the way, but these are just some of the initiatives that we had been working on implementing kind of in pre-pandemic mode at the APHA Foundation, trying to demonstrate the differences that were made. If you'll go to the next slide, you can see that one of the areas of focus was in diabetes. And if you look at these terrible statistics in our country, in each one of these cases, pharmacists can play a really extraordinary role in advancing individual people's health, but more importantly, perhaps to us all, is collectively population health at large. And in the lower right-hand corner of this slide, you'll also notice that we have a typical reduction of $1,000 per patient per year expected in terms of net savings that could come if you get the pharmacist well engaged on the team. So the next slide shows a series of different initials. We supported publication of the Asheville Project results, which started in '97 in one geographic area with just 2 employers. You saw a total of $1,600 to $3,300 in net savings per year. That was followed by the implementation of our patient self-management program for diabetes in '02 through '05 in 5 different geographies that essentially replicated year 1 clinical and humanistic outcomes, and also was very close with the $918 net saving per patient per year. We moved on to the Diabetes 10 City Challenge, which, as you might guess, happened in 10 different cities or 10 different geographies. And then basically implemented Project Impact Diabetes in a medically underserved population that was disproportionately affected individuals, mostly under and uninsured, and were able to achieve those same year 1 clinical and humanistic outcomes for our patients. So on the next slide, you'll see information about additional work that we're doing to try and prevent diabetes. So our foundation is a recognized CDC umbrella hub, one of about 11 in the country today. And we also have CMS Medicare DPP supplier status. So the 4th quarter of this year, we'll be moving on with the work that we've done with our affiliate Kroger over the course of the last 5 or so years in the 6-year initiative. And we'll be spreading out to partner up now with some new partners. McKesson is our first one that will be publicly announced soon beyond this webinar. And ultimately, we'll be seeing several hundred independent community pharmacists sign on to that initiative and basically be trained up as lifestyle coaches and actually compensated for their services. If we move on to the next slide, you'll see that additionally, some of the work that we've been teaming up with other members of Team APHA to address are these vaccine confidence issues. So we've just finished 3 different waves of demonstration projects where we have enrolled collectively over 6,000 patients and demonstrated that the pharmacist working together with the patient and other members of the healthcare team can actually dramatically enhance patient confidence in their vaccines and really help us to move to a place where we have very few unmet needs left over a period of months in these patients experiencing the team-based care. So if we go to the next slide, essentially, this is another one of our current initiatives. It's a 2-year demonstration project in the area of continuous glucose monitoring. And in this initiative, like the next one that I'll talk about, pharmacists are actually credentialed and paid for the team-based care that they're delivering, just like their physician colleagues. And so we're really excited about some of the potential breakthroughs here. Our independent practices are underway, and we have about 10 or 12 new chain pharmacy practices that'll be joining us here in the next few weeks. So if you go to the next slide, you'll see information about one of our projects that we just completed, Solutions for Atrial Fib Advocacy. Since we're a 501c3 charitable nonprofit, we know it's okay to educate and a little touchy to advocate. So advocacy is our play on those words. And this was a really exciting initiative where we utilize this little device in the lower right-hand corner of the screen. It's called the Cardiometabolic 6-lead device. And essentially, it provides you with a medical grade single lead EKG within 30 seconds. If you hold on to those two silver leads you can see on the other side. And then there's a third lead on the back behind the black section with the up arrow on it, that if you touch it to your left knee or your left ankle, you can actually get a 6-lead medical grade EKG. And so this is really exciting because within 30 seconds, the pharmacist can integrate this information in with a safety risk assessment that they've done to identify people who have abnormal rhythms. And as we know, the majority of people that have atrial fib are out there walking around with it and they don't even know it. And so this provides us an opportunity to identify and refer those patients. So the results of this project have been published, and the key take-home message is that this process of care resulted in the detection of more than twice as many patients with AFib in these practices as compared to the expected population prevalence in the United States. So there's a lot of excitement about this. And the great news is that if you go on to the next slide, we already have a sponsor in the BMS Foundation who stepped up to fund an initiative that we're referring to as Project Impact Cardiovascular Health Plus. The plus part are activities related to the pharmacist's assessment of social determinants of health that are helping them to engage in meaningful ways with patients. But also, this project is just like the CGM initiative, in that pharmacists are credentialed and paid just like their physician colleagues, utilizing the same CPT codes, and actually, with the initial referral and the ongoing monitoring and management services. Additionally, this project is being implemented in 20 different states, which covers 2 Medicare Administrative Contractor regions, to really try and demonstrate the role of the pharmacist in a more comprehensive and scaled way related to the potential improvements in cardiovascular health. So if we go on to the next slide, you'll see that this is just a short listing of the current active projects that we've got in play right now. And so without going into all of them, and there won't be a quiz on any of this, but the reality is that we have a number of interprofessional care delivery, patient-centered team-based care initiatives, as you've heard about, and a lot of work going on, and even more interest in doing more work in the future. So we're really excited to be able to provide you with just a glimpse of what the APHA Foundation as one organization has been doing related to patient-centered team-based care. So if we go to the next slide, essentially, this is happening through participants, providers joining on and signing on to our Impact Care Transformation Network, and it's making the acceleration of all of this work more feasible, and making it happen quicker. So we're really excited about the advances there. And on the next slide, you'll kind of see the thumbnail of where we're at as an organization and what we do. But you can see all of these different models where we've got evidence base with the check marks, and we've talked about the net savings. And ultimately, we move along this innovation arc, which you'll see in another couple of slides forward as well. So if we can go to the next one. We're all about doing the right things well, and we think there's a huge opportunity to change the landscape for how care is delivered in communities across the country. Pharmacies provide an important omni-channel access point throughout the country. patient-centered team-based care that includes practice settings that 90% of the US population is within 5 miles of, can do extraordinary things. And these approaches that support patients and meet them where they are while flexing with them as they participate in the program is super important. And finally, we'll go to the next slide in preparation for Elisa's remarks coming up. And I'll just ask you to think for a minute about, what could we all do together to try and take the evidence base about what we know works and make that more prevalent across the United States? And what could an interprofessional effort to improve just access and adherence accomplish? And how can we get all of our groups working together and align those incentives to improve the outcomes and control the costs, and really get after this agenda in a sustainable and a scalable way all across the country? So I'm going to leave it there and turn it over to my colleague, Dr. Elisa Bernstein.
Yeah, hi, thank you. Yeah, I know I'm absolutely biased by saying this, Ben, but tremendous, exciting work that the APHA Foundation is doing under your leadership, so kudos. What I'm going to talk about is the current state of pharmacist patient care services and give you a picture of really what's going on across the country, so you could see what the opportunities are for pharmacists to provide pharmacist patient care services, as well as where those gaps are and how do we fill those gaps. And then we'll have a later discussion about that a little bit later. So if we go to the next slide. So actually, Ben just talked about this, that 90% of Americans live within 5 miles of a pharmacy. So pharmacists are the most accessible healthcare provider. And when we're talking about providing care across the country and filling those gaps and health equity, 56% of pharmacies are in medically underserved areas or where there are health professional shortages based on data that comes from the government. So the numbers are actually a little bit higher when you even expand that in terms of underserved communities. So if we can go to the next slide. One of the things that, as Ben demonstrated, is data is powerful. As we all know on here, data is powerful. And John Grabenstein, a pharmacist, and put together and published a study last year that really collated all of the information and data and of how pharmacists provided care during COVID. And it's just incredible when you really look at it and you look at the numbers that it's well over 300 million COVID vaccines. And now that the whole country is, it's recommended to get boosters, that's certainly going to be increased by patients going to pharmacies for their booster. But it also translated to greater access as well as cost savings. So we'll go to the next slide, please. But there are threats to access to pharmacist patient care services, tremendous economic pressures right now on pharmacies. And this is a whole other talk, but the economic pressures and incentives, the incentives right now for pharmacy reimbursement are just misaligned, and pharmacies are getting paid at amounts less than what they actually pay for the drug. So it's hard to keep pharmacy doors open right now. And so that pharmacy sustainability and providing care is hard, and pharmacies are closing. And if we go to the next slide, you'll see we have pharmacy deserts. And a pharmacy desert is is where there are pharmacy shortages. And the USC and some other partners have created this mapping tool that helps show and really focus in and laser in and see where these pharmacy deserts are. And they've shown that 1 in 4 neighborhoods across the country have a pharmacy shortage. So a big reason for that is because of the economic pressures on pharmacies to keep the doors open. Let's go to the next slide. The other threat is scope of practice and having the ability to provide the care that pharmacists are licensed and trained to provide. And so the next few slides show a little bit about what that scope is across the country, whether it's prescriptive authority or under a statewide protocol or in a collaborative practice agreement with another prescriber. So, and it's all still looking at that team-based care approach. So what we have here is a growing number of states are providing authority for test and treat for acute ailments. And that includes not just respiratory, but also minor ailments that would require some sort of ability for first aid that's a little bit above what is more in the OTC care arena. But you could see it's starting to progress, but more than half the states pharmacists do not have any authority. And if we go to the next one, I think it's about 1.2 million Americans are living with HIV, and there are PrEP and PEP treatments and prophylactic treatments that are available, and they need to be used more often and more accessible. And pharmacists are also one area, and pharmacies are one area where PEP and PrEP could be provided. And you could see here that there's a growing trend, but it's still very little. So it's just kind of starting to shift across the country of finding ways to use pharmacists to provide that access to these products. We go to the next slide. Another area is, we have all healthcare providers are all in trying to address opioid use disorder. And so for pharmacists, this also is an area where pharmacists can provide patient care services, whether again through prescriptive authority or in an arrangement or collaborative practice or protocol. And you can see here, again, the numbers are small, but there are tremendous opportunity here to really break down the barriers in order to allow pharmacists to provide that access to care. And on the next slide, here's the other big barrier, and that is payment. We've been providing a lot of this care for free, and that is not sustainable, and that is not a good business model. I think all of you will agree to that and with that. And so what this slide shows is how are pharmacists getting paid across the country in the different plans, whether it's a commercial plan, Medicaid, or Medicare, or other types. So pharmacists are not paid under Medicare. They're not providers under Medicare. So for the most part, this is within commercial plans or Medicaid. And it's spotty, it's not consistent across the country. So one way, as I said, pharmacists are not providers for Medicare. And as I talked about earlier, and as we all know, there was significant access to care provided by pharmacists for testing, treating, and immunizing during the COVID pandemic. And so in order to make the ability of pharmacists to continue to provide this care and get paid for it, and as we have this bill called ECAPS, the Equitable Community Access to Pharmacist Services Act. This bill has been introduced in the House and the Senate. It is moving along. Right now, the Congressional Budget Office is putting a price tag on this, which is the score, which is an important step for legislation to move within the US Congress. And what this would do is enable pharmacists to be providers for our nation's seniors under Medicare for testing, treating, and vaccination of a number of respiratory illnesses. And so it's really right here on the slide, so I won't go over it. And this is where we need help in order to get this across the finish line. And if we go to the next slide, there are currently over 190 groups who have signed on to support this. So thank you for those of you who are on this webinar who have already supported it, and hope that others will continue to support this as well. And if we go to the next slide, this just shows one of the key pieces of that legislation is it creates a reimbursement pathway for pharmacists. It creates the ability for pharmacists to get paid, or to actually get paid for these as well, but it defers to state scope of practice, which is what controls the license for pharmacists. So if you look across the country to see, so where is that scope of authority, the next 3 slides show how pharmacists can actually provide those care models within the state. So here for administering vaccines, it's pretty uniform across the country that if you're a senior and you want to get your vaccine or your immunization, or then you can get it at a pharmacy in most states across the country. If you go to if we go to the next slide, this is test and treat. As I talked to you earlier, test and treat is more spotty across the country. And so this is an area of focus specifically for these 3 infections and testing for these 3 infections and treating for these as well. So a lot more work to be done here across the country. And then in the final slide, the next slide. Isn't there a next slide? No.
This is the 3rd of 3.
Oh, okay, great. Thank you. Sorry. Well, this is the final slide. So what we're going to talk about later is kind of pulling this all together, what can be done, how you all on this call, on the webinar, can help, and really figuring out how to help there. Thank you. How to help get pharmacists more pharmacist accessible care more available in communities across the country. So thank you.
All right. Good afternoon, everyone. I'm Dr. Warren Jones. I want to thank Dr. Bernstein for that excellent discussion of issues and opportunities. And I wanted to just share a physician's perspective on team-based care and the role that pharmacists can play. I was just sharing with my colleagues before we began this, that way back when the earth was cooling in the 80s, and I was running a residency program, I began to bring the pharmacists into our morning reports so that our residents could learn, have a better understanding of the way the medications interacted with the patients we admitted through the day. It really began to galvanize the early parts of team-based care, and many of them brought that with them as they traveled around the country. Team-based care is so critically important to dealing with the issues that our patients face, especially in the cardiovascular area. One of the problems is that some people feel we're preaching to the choir, but we need more preachers and bigger choirs. We have a huge percentage of our population that are not being adequately treated to care. And many times it's because they may see a primary care physician or referral person only once every 3 months, whereas they have access to their pharmacist on a much regular basis. So having a team-based approach that includes that pharmacist will help to make a difference. I function out of Mississippi, and I can tell you that as I ran my state's Medicaid program, and I was rolling out the concept of the medical home, the issues that our patients dealt with were oftentimes answered in their local community pharmacy, rather than waiting for an appointment to get back with their primary care doc. The problem is we've got to work together, and the ability to do that to help to think about what's in our patient's best interests. We heard discussion about a lot of programs that are out there, and these programs have been building the evidence about how we can make a difference that not only adds years to people's lives, but adds life to those years. And the way that we can do that is by leveraging all of the components of the team to help to make sure we have outcome. You just heard some discussions about the economics of healthcare. When you look at the ECAPS program that's been the legislation is offering, it really makes a difference, because what we found in primary care and family medicine especially is that when there's no margin, there's no mission. If you don't have the ability to recoup your costs and provide the services and to support your staff, then you can't meet the needs of your communities. So I'd ask those that are interested in supporting those kinds of things to make sure that we do all that we can. The importance of the community pharmacists was really underscored during the pandemic, because every hospital, every physician's office was overwhelmed, and many of the pharmacies were overwhelmed as well. But when the opportunities came to be able to offer vaccines, that was the pathway that allowed many of our patients to be sure to get the vaccines in a safe, informed environment, and a place that they can ask questions about the impacts or what they thought might have been side effects of their vaccines. The reality is, a lot of people had fear about talking with their pharmacists, but I need them to understand that the pharmacist in your community is an integral part of your care delivery team. And it's that team that's going to help to make a difference for us as we go on to do those things to make our communities safer. I would simply say, when you run into your local pharmacist, give them a hug and say, thanks for being a part of my team, because all of those things will make a difference. And to show you just how critically important this is, I'm going to pass on to a video that will show, among other things, a patient describing their experience with their clinical pharmacists.
I've had people come to me in tears, literally just thankful that they had this opportunity to really talk to a pharmacist. I can't explain how valuable it is, other than the fact that it's changing people's lives.
And that's what really I've seen make the change in people and allow them to be more vested in their health, because there's someone that cares about them, you know, to know that they have a coach that is helping them through that process. I think really empowers them, and they want to do better, and they do better.
It's made a big difference in my life because I got more confidence, you know, and I feel assured that everything is going to be all right because I'm taking all the right steps.
I think Elisa and I are ready to have some dialogue here about how we can all work together on some action steps that can help us to, you know, leverage this important evidence base that we've got about patient-centered team-based care, and to make it real in more communities across the country. And so I'll maybe just toss it over to Elisa to jump in and give us her insights and perspectives on, you know, what are the things at the top of her list as an important leader in our profession that could help us be successful with contributing in even more productive ways to the collective health and well-being of the population that we all serve.
Great, thanks, Ben. Yeah, you know, it's a great question, and you know, there is, as we've heard and seen, that there's a lot of good team-based care and pharmacist services going on around the country, and getting that message out is important. Data and experiences is what tells a story and helps people become comfortable, whether it's legislators and policymakers or patients themselves, in understanding that they can go to a pharmacist for care and that it is acceptable. And so having and collecting that data and those experiences in a way that others can tap into is so important. And particularly having it published. And bringing those stories to your legislators and policymakers, that goes a long way, especially when it's a personal story. And if you, let's say you're a pharmacist and you invite a policymaker to your pharmacy to talk to patients, to see exactly what you do, and bring some of the other healthcare professionals that you work with to show how the relationship works. that goes a long way. You know, a story and a picture go a long way, but actually talking it through and giving that policymaker the opportunity to ask questions is really important as well.
And Ben, this is a unique time for those of us who are healthcare providers. There's so much disinformation that has been spread recently, and so much questioning of the benefits of care, of intervention. That's why we've got to work together as a team to help to make sure that the patients for whom we provide care do retain a focus on what's in their best interest, and we can all reinforce that. I think the key thing is to not have fear to go and ask a question, because when my patients come to me and ask a question that I don't know the answer to, let's look it up together or I refer them to someone that can. And to have another resource that's a trusted resource to which they can turn will always be very helpful.
Absolutely.
Oh yeah, go ahead. No, go ahead,
Go
Ben.
ahead, Elisa.
I was going to say, and it's a two-way street. If a pharmacist is talking with a patient, and there is that opportunity where all of a sudden, if you can't answer the question, or you recognize that you really should talk to your healthcare provider, that's where referrals come into play, and pharmacists do that all the time.
Yeah, we generally see kind of two different categories of advanced service delivery in community pharmacy practices. You've got the prevention-related activities. When I was trained, we used to call them the hippy-dippy stuff, the health promotion, disease prevention activities, right? And so, you've got health and wellness screenings that occur. You've got vaccinations that are happening, obviously at a significant scale now in community pharmacies. But some of the programs that I was talking about, we talked about the cardiovascular health screening program. We also implemented a number of years ago a program that screens people for who might be at risk for future fracture, people who have osteoporosis and they're out there walking around with it and they don't even know it. And so I think that you've got all of those kinds of prevention-related services, and probably, a big capstone for us is that the last 5 or 6 years of working on diabetes prevention. And now we have a pathway where we're able to get pharmacies involved that's being supported by, CMS, and a number of the state Medicaid agencies are now starting to come along, but very few. Only a handful or so do we have coverage like that. And we need to do everything we can to invest in those prevention-related activities. But then, of course, on the other side of the fence, you've got the health management components. And so whether you're talking about cardiovascular health management or diabetes management, one of the projects I didn't really talk much about that we did a number of years ago was Project Impact Depression, where we actually looked at the role of the pharmacist in behavioral health and what they could do to actually bend the curve there. And so I think to the point that you were making, Dr. Jones, we have lots of opportunities, and I kind of think of it on both sides of that fence, where essentially we get our pharmacy teams involved in the prevention-related activities, and that might be more than just the pharmacists. Our pharmacy technicians might be actively involved, community health workers in those practices. And then on the other side, you've got more complex cardiometabolic conditions where the pharmacist's expertise can be so valuable to patients and to all of the members of the team in terms of helping to not only make sure that the right therapeutic decisions get made, but that we're actually treating people effectively and to goal, and being eyes and ears for physicians and communicating back with them, because the pharmacist might see that patient 12 to 15 times a year, whereas the physician might see them only once or twice. And so keeping that seamless flow of information between and among the members of the team is really an important aspect of all of this. But, the environment that Elisa was talking about, maybe I'll toss it back over to her, because there are some big challenges out there right now. And unless we figure out how to collectively take action in the near term here, a lot of those, opportunities that we've just discussed today and that are potentially out there may be at risk.
Yeah, I mean, yeah, that's a whole other webinar. But let me just say, I think there are some areas also, regardless of what type of healthcare provider you are, there are barriers to care that impact all of us, whether it's the prior auth steps that you need to go through. That takes up time. You may lose the opportunity to provide care to your patient, or you may end up not even able to provide the care that was originally intended. So those are things in terms of there are policy areas and barriers to providing more thorough care, robust care, that working together. There's also the whole the reimbursement. Reimbursement's an issue across the board. It's not just pharmacies, it's all across the healthcare community. And so, and it's all about the incentives and realigning the incentives. And pharmacy can't do this alone. And so I think it's also another area where there are things where we can work together. I think the other area that is a fear of scope creep. How do we get over that with some parts of organized medicine afraid that pharmacists are going to come in and take their job and their role, but that's not the case. It's collaborative, and how do we get that across to those who are trying to oppose some of these advancements in the states? I will stop there because I can go on.
Well, it reminds me, we had a physician who came to the podium at the National Press Club about one of our projects, and I hadn't talked to him before the event. I didn't know what he was going to say, but he stepped up to the podium and he said, "Folks," he said, "the first thing I want to tell you is that there aren't enough healthcare providers on the planet to get this job done. And we simply have to find smarter, more effective ways to work together as a team." And then he proceeded to tell the story of how pharmacists in the local food pharmacy chain where he lived had really stepped up and had helped him to improve access to patients and information about how his patients were doing that had really changed people's lives. And so, anyway.
I'm wondering, Elisa, Ben, looking at the maps that you showed, clearly, there's some wonderful programs that are going on out there. And this CMS recognition that pharmacists can be important providers in a diabetes prevention program, it feels like the rate limiting step is at the state level, where the scope of practice is often constrained. And curious to your experience in terms of what's been most effective in helping those states that were the right colors on the map open things up a little bit.
Yeah, no, that's a really good question. And it's interesting when you said the right colors on the map, you're talking about the colors on the maps that I showed, not necessarily a red color or a blue color because that doesn't have anything to do with it, really, in terms of the politics aren't.
Right.
It's what resonates the most. And particularly a lot of the advancement has been happening in states in where there's a high rural population, or there are those healthcare provider shortages, and really demonstrating that pharmacists can step in and provide that care. And that's where the providers in those states have been telling those stories, demonstrating how they can help, demonstrating how they can work together to show that progress. And that's what, going back to what I was saying before, is having the data and the information and the stories from one state or one region can resonate in other areas as well, in those areas that are similar in terms of other states that have rural areas or healthcare professional health provider shortages.
So in terms of the data being fairly specific, it's probably a combination of the provider density or the lack of access to the providers, as well as what I think might be supplemental is some of the health conditions that organizations like the University of Wisconsin doing their county by county data health assessment marrying those two sets of data can be pretty powerful, I would assume.
Absolutely. You know, another is we at APHA work very closely with the state pharmacy associations. So they know what's happening in their communities across the state. They know what resonates with the policymakers and actually building those relationships. And when I say policymakers, it's not just the legislators. It's the boards of pharmacy. It's the public health departments, because they all have to work together in order to set up that runway and the path and the place for pharmacists, patient care services within the whole continuum of care.
Yeah, you know, it's interesting having seen the opportunity to be inside integrated models of care where pharmacists are just an important part of the team from the get-go, and looking at communities where that's the norm. And looking at what some of the outcomes are in terms of health outcomes and economic outcomes, as compared to communities where there's still this sort of isolation and pharmacy hasn't been integrated into the care team as effectively. It's another, I think, powerful data to tell the story.
And a good thing about it is that our young professionals coming out are getting exposed to interprofessional team and interprofessional education. So they're coming out prepared to step in. The problem is many of the places they go, they're not prepared to be received. The communities aren't prepared to receive them. I taught a lot of interprofessional care courses when I was chief health officer at Hampton University. And I can tell you that the young professionals, they were ready. They understood how to relate. So the question is, how do we get beyond the thought of I must guard my own rice bowl, the kinds of decisions that are being made within the states and within regions? And that's when we look to folks like you guys that are experts and some of the experts that are viewing this session. We've got to work together. When we have as many HPSAs and MUAs as we have, HPSAs, health profession shortage areas, and MUAs, medically underserved areas, and in those areas, the life expectancy is low, general health parameters are bad. So why are we fighting against the opportunity to bring better care to those areas? And that's the name of the game. How do we help people to not only live longer, but to live better in the process? And I believe what we've talked about today can help to play a role in that.
Absolutely. Looking to see if there weren't any questions that I've seen posted. I see some comments, particularly there's one from a PharmD who's out there working in the community, who's really excited to hear about all of the advancements that your organizations are putting forth. So kudos from the participants. You know, I'm curious with Elisa and Ben, given the sort of range of services that pharmacists have proven to be effective in providing on the preventive side and now in the diagnostic and the treatment side, do you feel that there's an easier path forward with a set of services to be able to expand the scope? I know we'd love to get it all because of what, you know, Warren just described and what we've been challenged with in terms of there's so much of the population that just needs more. But wondering, given that breadth of services, is there an area that you think the initial push might be more effective in?
Yeah, you know, really good question to follow on Dr. Jones's previous statement, because so there has been some legislation that's been introduced in the U.S. Congress for several years, and in fact was just reintroduced earlier this year in the Senate, that would open the door for pharmacists to provide care in medically underserved and health provider shortage areas, generally, broadly, and based on the scope of practice. So it was focused there. The problem over the many years is that that price tag, that score, was just too high, or it actually was never really scored, but the anticipated score was too high. So to answer your question, so where does ECAPS come in? The one that I was talking about for test and treat and immunization. That's kind of a narrower, low-hanging fruit where the data and the experience that we've just gone through during COVID really tells the story of how pharmacists can provide that care. So it is considerably narrow, but it is that opening and getting pharmacists as providers then in the Social Security Act really kind of opens that door to providing more care. So, yeah, that's that low-hanging fruit, but the care that pharmacists are providing in the cardiovascular space and diabetes care across the country has been tremendous. So how do we, and some of the work that Ben was just showing, so harnessing that to really bring that to our nation's seniors, which is a population that can really benefit from that, is so important.
So one of the key takeaways I would infer is that we should all go out and make sure that we touch base with our congressional representatives to fully support ECAPS as one key next step that we can all advocate for, except you, Ben. I understand. you can advocate, but you can't advocate.
I'll advocate for it.
There you go.
But he can advocate as an individual, not
That's
as an
true.
organization. There you
That's
go.
right.
So you have a very potent voice.
And there's another comment here that comes from one of the participants suggesting that engaging the boards of pharmacies at the state level can be very helpful for the scope question as well as the credentialing by the third-party payers. So I think there's another key step and takeaway from this conversation. We're kind of near the end of the allotted hour. Let me just open it back up to the three of you. If there are any specific takeaways that we haven't touched upon that you want to make sure that our participants will carry forward from this conversation. So why don't we start with you, Elisa?
Well, you stole my thunder in terms of the takeaway, the ask. Yeah, support ECAPS. And tell others as well to support it. Bring if you're a pharmacist, bring your policymaker, your legislator to your place of practice. Show them what you do. Show them all the patient care services that you provide.
Great, thanks, Ben.
Yeah, I think I'll leave everybody. Well, first of all, thanks to everybody for attending today. But I think one of the best ways to invent that preferred future that we're all really seeking with, collectively a lot of patient-centered team-based care going on throughout the country is to collaborate with your pharmacist.
Great. Thank you. And Warren?
In some communities, there may be fear among clinicians that if someone else enters the expanded scope of practice phase, that it may adversely impact them. I think there needs to be meaningful dialogue and recurrent dialogue to help raise the general level of knowledge, to say that this is not an attempt to displace you, but an attempt to complement you. And I would simply ask those of us who are in attendance to bring that message out and have folks to understand that the better we work together, the more effectively we work to support our patients, hopefully the better the outcomes will be for them, no matter
Great.
what the score is. Okay.
Great. Thanks, Warren. And thanks to all of you. Thanks to all of you on the panel for your insights and experience. And thanks to all of you who participated. I just want to remind all of the participants that there is a survey that is there in the chat, and we'd love for you to just take the survey so we can make sure that we're meeting the needs of you as participants going forward. So thank you all, and everybody have a great rest of the day.